center started in Bagalkot in 2006, the primary referral of the link worker was to the ART center for pre-ART registration and CD4 testing. With this, PLHIV could access a whole gamut of services which are available at both Jeevan Jyoti clinics as well as the ART center. PLHIV would then be followed up in the field as to whether they are started on ART and followed also on the ART adherence. Once a sufficient rapport was built up with the PLHIV, inquiry would be made into the status of his spouse and his children, and they would be also appropriately referred. Any home-based care services which were required by the PLHIV in the field would be addressed by the link worker with the available services at the sub-center and at the PHC. If the PLHIV is sick of opportunistic infections, a referral would also be given to the community care center which is at Bagalkot and at Jamkhandi taluks. The second important target of the link worker in the community was most at-risk population. This population comprised of men and women with high-risk behavior, people living with HIV and their spouses, and the spouses of those who were engaged in high-risk behavior. Most at-risk population were referred to the STI clinics in the selected villages. A cross-referral would also be given for testing services available at the VCTC. Those most at-risk population who were detected to have HIV would appropriately be referred for ART services as well as to the comprehensive services available at Jeevan Jyoti outreach clinics. The link worker would mobilize positive pregnant women in large numbers to avail PPTCT services available at the district and taluka hospitals. Those pregnant women who would disclose their status to the link worker were referred for services at the ART center. Those positive pregnant women who were not eligible for ART and were not started on ART by the ART center, the link worker would then follow them up extensively in the field and would assist for nevirapine prophylaxis to the mother-baby pair at the time of delivery. The mother-baby pair were followed up till 18 months of age, and testing of the infant was encouraged at 18 months of age. If the infant was found to be positive, the link worker would assist the pair to avail comprehensive services available at the PPTCT and at the ART center.
Every district in Karnataka now has at least one ART center at the district hospital or medical college, and Bagalkot is one of them. Bagalkot has the largest number of individuals registered at a district hospital level ART center, indicative of the growing burden of HIV in this district. It is the only district in the state where every one of the 6 talukas has been approved to have a link ART center. Keeping PLHIV at the center of interventions is essential to any care, treatment and support program. Psychosocial needs and psychological well-being comes up as the foremost priority, and hence our attempt was to improve both the numbers and the quality of HIV care counseling. Medical services are the second need, and the itinerant services offered through Jeevan Jyoti, complemented by the inpatient care at Arunodaya and other community care centers, support the ART offered at the district hospital. The attempts made at nutrition interventions are minimalistic, and more needs to be done in this area. Positive prevention through condom promotion and STI screening and treatment have been given attention. Linkage to educational and vocational services, referrals to other social sector services, and advocacy with departments support livelihood options, and finally, home-based care is offered to the small proportion of those too sick to travel to a facility for care.
At the community level, link workers are the primary caregivers in all villages where HIV is concentrated. Where HIV-infected people are few and far dispersed, the local A&M or the Anganwadi worker and ASHA take on this added responsibility of education, basic service provision and referral to an HIV care center. Peer outreach workers from Jeevana Jyoti and the community care centers are responsible for tracking loss to follow up, community mobilization, organization of medical and other service delivery, and addressing stigma and discrimination within rural and urban areas at the taluka level. To get a more long-term view on the continuum of care and support, we need to look at the IMAI approach and assess its significance and importance.
It was in 2006 that the WHO's or the World Health Organization's IMAI approach, or the Integrated Management of Adolescent and Adult Illness, brought in the element of not just assessing, agreeing and advising, but also moved into elements of assisting and arranging for HIV care. From a stage of only symptom-related management of people living with HIV and AIDS, people now began to look more comprehensively at the overall medical needs. Assessing for family status, looking at family planning and reproductive health needs, looking at tuberculosis screening and treatment, and readiness for antiretroviral therapy and adherence thereafter. From a stage of only symptom-related management of people living with HIV/AIDS, people now began to look more comprehensively at the overall medical needs. It is the IMAI approach that helped us to understand different interventions are required at different stages of HIV illness. At the stage of HIV diagnosis, it is important to deal with psychosocial behaviors, to deal with preventive behaviors, and to deal with health-seeking behaviors. Later in the disease, it is important to look at nutrition interventions and the treatment of opportunistic infections. In clinical stage 3 and 4, it would be important to not only treat infections, but also prevent the most common opportunistic infections. Antiretroviral therapy gets introduced at this stage, and nutrition interventions need to be more intensive. Even in the last stages of HIV, measures to address bereavement, to look after children orphaned and vulnerable as a result of HIV, and to address social security concerns of people living with HIV and their families remain a challenge. Throughout the stages of illness, legal support, socio-economic support, nutrition support, and measures to address the children need to be looked into. Thus, the IMAI approach did help us to prioritize interventions according to the stage of illness that an individual goes through. The care treatment support initiatives demand a continuum in capacity building initiatives. Thus, the IMAI approach is used as the induction module where the doctor, nurse and counselor come together to be trained using the expert patient trainer method. Beyond the induction training, clinical mentorship of teams of doctors, nurses and counselors is provided on-site at the community care centers and drop-in centers. The Samastha HIV e-learning package, or the online website, or what is commonly referred to as the Samastha Help, aims to keep doctors updated with the rapid medical advances. Learning sites provide the opportunity for hands-on experiential learning and also help us to develop protocols required for admission, discharge, or death of patients. In conclusion, we would acknowledge that yes, ART centers do provide the life-saving ART, which helps us to add years to life, improving the duration of life. It is the community care centers that provide the care, treatment and support that help to add quality to life. And it is the drop-in centers or the integrated positive prevention and care centers that help each person to support the other, thus adding quality to lives. We hope that our journey with you over the next few days will help you discover this continuum of care within the district through the different services and community initiatives that have been going on in Bagalkot since the last 5 years. Thank you.